It's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers. And the question last week was a case study. My mum has been in ICU ventilated with a breathing tube in an induced coma for 5 days. Is a tracheostomy too early? You can check out last week's episode and case study by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer another question from one of our clients, which again is an excerpt from a one-on-one phone counselling and consulting session with me. And the question this week is another case study. My mum has ventilator-associated pneumonia and is on the ventilator in intensive care. I don't want to have her tracheostomy. Will she cope being extubated and on BIPAP? This is another great case study where I have helped a very concerned daughter who had her mum in intensive care and guided her in the right direction because of my insights and experience. So Mandy writes, "Hi Patrick, my 78-year-old mum is in intensive care, ventilated with a breathing tube and in an induced coma. She was admitted to intensive care after she had a fall in the nursing home she's residing at. She got intubated and then eventually developed a ventilator-associated pneumonia after about a week on the ventilator and in the induced coma. Now, a ventilator-associated pneumonia, also known as VAP, is a type of lung infection that occurs in people who are on mechanical ventilation breathing machines in hospitals. As such, VAP typically affects critically ill people that are in an intensive care unit, and VAP is a major source of increased illness and death." Now Mandy continues writing, "They are now trying to get my mum out of the induced coma to get her extubated, but she keeps failing to breathe by herself and she keeps failing her CPAP trials." Now let me explain. Extubation means removal of the breathing tube, and CPAP is a spontaneous ventilation mode often leading to the removal of the breathing tube. Again, and that's called extubation. Now Mandy continues to ask, have you seen an elderly patient with ventilator-associated pneumonia that has also failed CPAP trials thrive on BiPAP and resolve their respiratory distress after being extubated? So let me quickly explain the difference between CPAP and BiPAP. Now, CPAP is the spontaneous ventilator mode on the ventilator with the breathing tube, and BiPAP is often being used when patients are off the ventilator with the breathing tube, and BiPAP is being used with a face mask. Now, CPAP and BiPAP can both be used whilst somebody is on a breathing tube or whilst somebody is on a ventilation mask, but the most comfortable and also effective breathing mode or ventilation mode on a mask is usually called BiPAP. So Mandy continues to write, also, if she keeps failing extubation, can the need for a short-term tracheostomy be predicted? How long does a tracheostomy site take to heal in the elderly? Also, if my mum needs a tracheostomy, what type of infections trend with tracheostomy patients, especially elderly, and how are those infections addressed? My mum is bedridden with contracted hands caused by dementia, prolonged delirium from UTIs. UTI stands for urinary tract infection. In addition to having a chronic Foley catheter, my mother has a feeding tube that has helped sustain her weight. She has consistently asked for and swallowed water at the nursing home. Tracheostomies appear laborious to me. How soon can someone speak after receiving one if they have been intubated for 10 or more days? Next, what type of end-of-life comfort can be initiated in ICU and how does it transfer with the patient to hospice? If all of the above fails, could reintubation with sedation be a humane transition to hospice? Many thanks from Mandy. And also quickly let me explain again, intubation means the insertion of a breathing tube. So here's my answer to Mandy's questions. Hi Mandy, thank you for being a client and thank you for signing up for my one-on-one phone and email counseling and consulting with me. From everything you are describing and from all the information that you provided, I can see the following. If your mother is failing the CPAP trials, she may not be quite ready to be extubated. CPAP again is a spontaneous breathing mode on the ventilator and is usually the last step before a critically ill patient can be taken off the ventilator and the breathing tube can be removed. Before your mother can be extubated, she also needs to start obeying simple commands like squeezing fingers. She needs to be able to have a good, strong cough so that she can protect her airway once she's off the ventilator. On top of all of that, she needs to have adequate oxygenation and her oxygen saturation should ideally be greater than 92% with satisfactory arterial blood gases. In an arterial blood gas, her oxygen levels in the blood should ideally be above 60 mm per mercury and carbon dioxide levels in the blood should be around 35 to 45 mm per mercury. Your mother should also show to be able to take good tidal volumes, which is shown in mils per breath on the ventilator, and she should be able to take breaths around 7 to 10 mils per kilo. I also hope that they have done some chest physiotherapy to strengthen your mother's ability to get off the ventilator, which would be particularly important if she's contracted with already limited mobility. Also, if your mother continues to be failing the CPAP trials, they may just need to wait a few more days until your mother is more awake after the induced coma. Especially in elderly patients, coming out of an induced coma can take a little longer, despite your mother being off sedatives for a few days. There are a number of articles that I put in this video, in the links below this video, that describe this process, how long it takes to wake up after an induced coma. So go and check out the written version of this blog on our website and click on the links that describe how long it takes to wake up after an induced coma. So therefore, a few more days of being patient might just help your mother to avoid the tracheostomy. Also, the longer a critically ill patient in intensive care stays ventilated, the higher the risk for a ventilator-associated pneumonia or VAP. I do strongly believe that getting your mother off the ventilator and extubated is the right thing to do besides the pneumonia. If, for whatever reason, she's struggling to breathe, they can always put her on the BIPAP. Again, BIPAP is a form of non-invasive ventilation with a face mask, as you have suggested. By not giving her the chance to breathe without the breathing tube first, a tracheostomy might be a little bit premature. There is a risk that despite the BiPAP mask, your mother needs to be reintubated, which again is the reinsertion of the breathing tube, and then have the tracheostomy. But not giving her a chance in the first place and maximize chances to get her off the breathing tube would not be in your mother's best interest. Also, once she's off the ventilator and the breathing tube, they need to continue chest physiotherapy and look at things like giving her nebulizers to loosen up secretions on her chest, especially in light of the ventilator-associated pneumonia. Mobilization and getting your mum out of bed would be critical too, and would improve her ability to breathe by herself. If BiPAP, chest physio, mobilization and nebulizers don't help, and your mother has to go back on the ventilator with the breathing tube, then you know for a fact that she will need a tracheostomy. Hopefully this then will only be a short-term tracheostomy, and just what I described above with chest physiotherapy, mobilization and nebulizers should continue. The main advantages of a tracheostomy are: no sedation is needed, as a tracheostomy is mainly pain-free and not as uncomfortable as a breathing tube. Next, the ability to suction secretions via a tracheostomy tube is much easier. Also, the ability to ventilate your mother intermittently and when needed, therefore increasing chances to wean your mother off the ventilator in her own time. And also, starting to talk with the aid of a speaking valve and with speech therapy. I have also put some links to articles below this video in the written version of this blog when patients should have a tracheostomy, and also what are the risks and benefits of a tracheostomy, and also tracheostomy and weaning off the ventilator in intensive care. How long can it take? So, if the ICU is doing all the right things, your mum hopefully can come off the ventilator within a few days, and then they would be working on removing the tracheostomy. This again all depends on whether your mum has a strong cough so that she can protect her airway without the tracheostomy. Once the tracheostomy has been removed, the tracheostomy site usually heals within a few days. Also, if a tracheostomy is well looked after, if the skin is being kept clean, if the inner tubes are changed regularly, and if either humidified air or oxygen are applied, there tends to be less infection risk compared to a breathing tube. If, for whatever reason, she does get another infection, they would be treated with antibiotics if there is any bacterial growth, just like with any other infection. There is also definitely a risk of aspiration with the tracheostomy. Therefore, the tracheostomy will need to be blocked with an air balloon so that no gastric or stomach content can enter the lungs. Once your mother is more stable, they should be able to get the air balloon down and do some speech and swallowing exercises. Tracheostomies can be laborious, but they are way more patient-friendly compared to breathing tubes stuck in the mouth. Next, you are asking what type of end-of-life comfort can be initiated in ICU and how does it transfer with the patient to hospice. Normally what happens is that ICUs either initiate end-of-life care in ICU if they think it'll be a relatively quick end-of-life situation. If they think it might be a prolonged end-of-life situation, they might offer hospice care, but it also depends on the availability of a hospice bed. If they do send patients to a hospice, they tend to send them without a breathing tube and without a ventilator. Now, from my perspective, Mandy, and from my experience, if your mother will end up with a tracheostomy, you may want to check out intensive care at home. Intensive care at home, from my perspective and from my experience, is usually the best option, and if needed, end-of-life care could be provided at home as well. Therefore, check out intensivecareathome.com. I hope this helps, Mandy, and let me know if you have any other questions. So, how can you become the best advocate for your critically ill loved one? Make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care. You get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you learn quickly how to make informed decisions, get peace of mind, real power, and real control, so that you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free instant impact report, you learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You'll get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You'll get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog and podcast section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Or you can call me, find international phone numbers on our contacts tab. Also, check out our ebook section where you get more ebooks, videos and audio recordings, and where you can also get one-on-one counseling and consulting with me via Skype, over the phone or via email by clicking on the products tab. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.